Well, thank you for taking the time to watch this presentation, and if you are involved in the STAND trial, I want to thank you in advance for all your support and your help with this trial. What I'd like to go over in the next hour is the fetal heart rate monitoring status of the science at this time, and then go through the basis for ST segment analysis, and then the basis for the trial that we would be starting, and hopefully your site will be participating in. Fetal heart rate monitoring was introduced in the 60s by Hahn and other colleagues, and it was mostly designed to monitor complicated pregnancies. The initial intent of fetal heart rate monitoring was to monitor complicated pregnancies. However, by the late 70s, 2/3 of pregnancies were being monitored by fetal heart rate monitoring. And as you know by now, most US women in labor are being monitored by external fetal heart rate monitoring. That was not the intent of fetal heart rate monitoring when it was introduced. If we superimpose the introduction of fetal heart rate monitoring to the rate of cesarean section over time, you can see that the cesarean section rates have increased dramatically after the introduction of intrapartum monitoring. And if we superimpose the time periods when 2/3 and most US women were being monitored, you can see that there was an uptake and an increase in the cesarean section rate following the increase in fetal heart rate monitoring. This phenomenon was not limited to the United States. I have here two other countries in Europe, the UK and Sweden, and as you can see, there was a significant increase in cesarean section rates following introduction of fetal monitoring. Now the graphs, the columns in blue show the cesarean section rates, while the columns in yellow show the cerebral palsy rates. And the expectation was, if we are doing more cesarean sections because of the introduction of fetal heart rate monitoring, that we would decrease cerebral palsy rate. But as you can see from this slide, there was no concomitant decrease in cerebral palsy rates. Now, all of these are circumstantial evidence and epidemiologic studies. However, the real study to determine the value of fetal heart rate monitoring has to be randomized trials. So let's look at the evidence of randomized trials. Let's look at the Cochrane Review. The Cochrane reviewed 12 clinical trials, 2 of which were of high quality. What's important to notice is that none of the trials included a non-monitoring arm in the control. So all the trials included a control arm that was some monitoring, mostly intermittent fetal heart rate monitoring, and most of the trials included or performed were old trials. No recent clinical trials. So if we look at continuous external fetal heart rate monitoring compared to intermittent auscultation, there was 11 trials included in this review, and as you can see, there were no differences in perinatal death. So continuous fetal heart rate monitoring as compared to intermittent auscultation did not significantly decrease perinatal death. There was a significant decrease in neonatal seizures, and we'll talk about that later, but there was no benefit as far as cerebral palsy. And actually, if you look at the point estimate for cerebral palsy, there was a 74% increase in cerebral palsy in the arm using continuous fetal heart rate monitoring. However, the 95% confidence interval crossed 1, and therefore the difference was not statistically significant. So at least we can say that there was no significant reduction in cerebral palsy from continuous external fetal monitoring. However, there was a significant increase in cesarean delivery, a 66% increase in cesarean deliveries, and this increase was statistically significant. If you look at the 95% confidence interval is above 1. And there was an increase in operative vaginal delivery, and again this difference was statistically significant. Let's go back to neonatal seizure. As I said, there was a significant reduction in neonatal seizure with continuous fetal heart rate monitoring. However, if you look at the top part of the forest plot, this significant reduction was only evident in the cases where fetal blood sampling was used in addition to continuous fetal heart rate monitoring. If continuous fetal heart rate monitoring was used without fetal blood sampling, there was no significant reduction in seizures, in neonatal seizures. So if we look at overall the evidence that's available for fetal heart rate monitoring, and I'm talking about the current way of monitoring the fetal heart rate, we can see that after the introduction of intrapartum monitoring, there was a significant rise in cesarean section rate that coincided with the increase in the use of fetal heart rate monitoring. And this increase in cesarean section rate and the studies have not shown that there was any reduction in cerebral palsy. So the association between the combination of increase in cesarean section rates and no benefit of fetal heart rate monitoring prompted the U.S. Preventive Task Force to give a grade D for fetal heart rate monitoring because there was no evidence of benefit and there was actually evidence of harm. A grade D is the worst grade that you can get for any intervention or any technology. So most of you are now thinking by now, why are we still using it, right? Well, it's mostly because of convenience. Remember that most of the studies used intermittent auscultation as the control arm. So no studies compared fetal heart rate monitoring to no monitoring at all. Therefore, you can say that continuous fetal heart rate monitoring may not be better than intermittent auscultation, but if we're not going to use fetal heart rate monitoring, we have to use some form of monitoring, which is intermittent auscultation, which means somebody has to be at the bedside intermittently listening to the fetal heart rate, and the recommendations are every 15 minutes in the first stage and every 5 minutes in the second stage, and documenting these fetal heart rate. And basically fetal heart rate monitoring replaced that just for convenience. Now, we could have predicted that fetal heart rate monitoring was not going to be beneficial to prevent cerebral palsy or prevent adverse neonatal outcome, and that's because fetal heart rate monitoring or fetal heart rate abnormalities are not good predictor of fetal acidosis. This graph shows the association between the various fetal heart rate patterns from the mostly normal to the most significant ones in the red. You notice that some are in green, some are in yellow, some are in red, depending on their severity and how much associated they are with acidosis. Now remember the green, yellow, and red because we'll come back to that when we talk about ST segment and STAN. But each of these fetal heart rate patterns was then associated with how many of the babies with these abnormalities had acidosis. The percentage on the x-axis is the percent of those who had acidosis less than 7.25, a pH less than 7.25, versus those that were normal with a pH above 7.25. Now, if you notice that this study from the 70s, at that time, acidosis was defined as a pH of 7.25. We know now that the acidosis definition requires a pH even much lower than that, either 7.0 or 7.05, depending where you practice or where you are in the world. And therefore, in your mind, you need to move that line, that the vertical line at 0, you need to move it more to the left, because that means less of these babies will be defined as acidosis on the x-axis from a percentage perspective. And if you do that, you can see that most fetal abnormalities are not associated with fetal acidosis, and very few of these babies will have fetal acidosis as defined by a 7.0 or 7.05. Even those that are in the red category, the late decelerations and the loss of baseline variability. So therefore, fetal heart rate monitoring is not a good predictor of fetal acidosis. Moreover, fetal heart rate monitoring is not a good predictor of the ultimate outcome that was to be prevented, which is cerebral palsy. This is a study from Karen Nelson and colleagues from some years ago. Karen Nelson is the world authority on cerebral palsy. And what these investigators did is they took all babies with multiple late decelerations and or decreased variability. And these were babies weighing more than 2,500 grams, so they were term babies. So they took fetal heart rate patterns that are the worst patterns that we worry about the most, and they looked at how many of them developed cerebral palsy. And if you look at the bottom right corner, the positive predictive value overall was 0.14%. That's 0.14%. That's not 14%, which means that of 100 or 1,000 baby with these decelerations, with these ominous fetal heart rate patterns, 1.4 in 1,000 will have cerebral palsy. So the positive predictive value is really, really low for these fetal heart rate patterns. I didn't do that. Some others, I've heard some others do that calculation, but it's interesting to think that we do cesarean sections for these fetal heart rate patterns to prevent. So we do cesarean section on 1,000 women for these fetal heart rate patterns to prevent one cerebral palsy, but out of the 1,000 we will probably end up with a couple of uterine ruptures in the next pregnancies, and these uterine ruptures are associated with cerebral palsy. So in a sense we're preventing one and making one cerebral palsy. Now, the other problem with fetal heart rate is also the variability in interpretation of the fetal heart rate. This is a nice study by Suneet Chauhan that looked at inter-observer variability, the variability between different observers who are reviewing these strips. So what they did, they took several fetal heart rate strips, showed them to experts, different experts. They showed the same strips to different experts, and then they determined how much agreement they had between the experts. Now that can be done with the statistical analysis using kappa coefficient that you can see that there, and then depending on these kappa coefficients the agreement can be categorized as poor, fair, moderate, good, substantial, or almost perfect. So looking at that table you can see that there was only one pattern that showed a good agreement. No pattern showed substantial or almost perfect agreement. The best they could achieve is good agreement, and that was one fetal heart rate pattern, which was tachycardia. So that means that most observers agreed that the heart rate is above 160. That's what tachycardia means. And even that, even as simple as agreeing that the baseline is above 160, was only good agreement. And the fetal heart rate pattern that we really typically use to document or use to determine fetal status, like beat-to-beat variability, decelerations, had only poor to fair agreement. Now this study is about inter-observer variability, but there are other studies looking at intra-observer variability, which means that the same person reviewing the same strips months later or 6 months later, a year later, and again the intra-observer variability was not very good. So we couldn't even agree among ourselves which tracing, what to call the fetal heart rate tracing. So you can see that it's not a good predictor of acidosis, it's not a good predictor of cerebral palsy, and it has a very big problem with interpretation. Now, taking all of these into consideration, NICHD, ACOG, and SMFM sponsored a working group or a workshop to look at whether we can improve the fetal heart rate monitoring, and they published their findings and recommendations in the Green Journal, and these were subsequently endorsed by ACOG in a ACOG practice bulletin, which I'm sure most of you are, or all of you are familiar with this, and if you're not, I encourage you to find it and read it, review it. In that bulletin, there were several recommendations and some changes from what we used to how we used to practice before. I'm not going to go through all of these changes, but I want to highlight the one important change, a major change that we should all be following right now, and that's the categorization of fetal heart rate. So as you may know, now there are 3 categories, category 1, 2, and 3. Category 1 being normal fetal heart rate, and they give the conditions to call it a normal, which is a normal baseline. Fetal heart rate variability has to be moderate, no late or variable decelerations. You can have early deceleration, that's okay, and accelerations can be present or absent. So that's normal category 1, very clear. Category 3 on the other extreme is the abnormal one, and as you can see, you have absent fetal heart rate variability, but that's not enough to have absent fetal heart rate variability. You also have to have one of the other 3, either recurrent late decelerations, recurrent variable decelerations, or bradycardia. And by the way, recurrent means present within 50% or more of the contractions. A sinusoidal pattern by itself also will put it at category 3. So it's important to note that absent fetal heart rate variability is not by itself, without the other any of the other 3, is not a category 3. That would be a category 2. So anything that's not category 1 or category 3 becomes category 2. As you can imagine, this category 2 is a very large category, and depending where you are and what type of patients you see, between 1/3 to 2/3 of the patients monitored intrapartum will have a category 2. So that's quite a large number of patients will be in this category 2. By the way, the ACOG provides some example of category 2, but these are not all the possible findings that belong to category 2. If you look at the title of this category 2, and up here you can see that these are examples of category 2 tracings, and not an extensive or a complete list of category 2 fetal heart rate tracing. So along with these categories, NIH and ACOG then came out with some suggestion for management of these. Category 1, very simple, normal fetal heart rate tracing is strongly predictive of normal acid-base status, and the management is to follow in a routine manner. Category 3 obviously is abnormal, predictive of abnormal acid base. There should be prompt evaluation required, and if there is no resolution of the pattern, then delivery would be indicated. So category 1, category 3, clear management recommendations. However, when we come to category 2, it's the indeterminate category, and again, a large proportion of the intrapartum patients will be in this category 2. The recommendations are continued re-evaluation, additional tests, and non-surgical intervention. So my question is, what are these additional tests? What additional tests are we going to use in category 2 to tell us what to do? Well, so we need a backup test. What these recommendations mean is that we need a backup test. Now, long time ago, and I'm going to start to show my age here. I don't know how many of you recall fetal scalp pH. When I was starting in obstetrics, we had to do all these scalp pHs, and my knees became calloused from having to kneel down to do all these scalp pHs, so some of you may still remember. That used to be used as a backup test when we're not sure about the meaning of the fetal heart rate patterns. However, not many hospitals in the U.S. use it. This is one of the latest ACOG survey, and it says at that time 3% of institutions in the U.S. use it. I'm not sure it's still valid now. I think it should be 0%. I'm not aware of any U.S. institution that uses it. It's still used in Europe, many places in Europe, even in Canada, as a backup test, but in the U.S. this is not a test that we have. You may ask why, and again, I think it's because of convenience. It's very hard to maintain these machines, to calibrate these machines, and with CLIA requirements now, the hospital had to go through a lot of paperwork and hoops, and plus the companies now don't sell the machine anymore in the United States. Now, you're all familiar with fetal pulse oximetry or continuous scalp pH. These are technologies that were introduced at some point in time, but they're not available anymore. Fetal pulse oximetry did not prove to be useful, so the company doesn't sell that equipment anymore. So we still don't have a good backup test in the US for these category 2 tracing. What we are proposing is that maybe ST analysis may become that backup test. We still need to determine whether ST analysis can be that backup test. Now, why do we believe that it can be the backup test? Why do we believe that it's worthwhile studying whether it's the backup test? Well, I gave you three reasons here, but hopefully in the next few slides I'll expand on that. Well, first, ST analysis was developed specifically for the purpose of being a backup test for fetal heart rate monitoring. It was specifically designed to fill this gap. It was tested in these situations, and I'll show you some of the studies, and it's also the only currently FDA-approved backup test for this particular indication. So what is ST analysis, or STAN as we call it? We're going to call it STAN, but it's really an ST analysis, the ST segment of the EKG. ST analysis developed over decades. It's not something that just came up a few years ago. We may have started hearing about it a few years ago, but the basis started in the 70s with animal experiments, and then phase 2, phase 3 trials, and now there are at least 5 randomized trials that have been performed using STAN technology or ST analysis in real clinical cases. I have here 4 of the studies, but there is a 5th recent one just came out recently. And as I said, the FDA approved the ST segment analysis in 2005, and it's important to note that the indication for the use of ST analysis as an adjunct to fetal heart rate monitoring, and I want to stress adjunct, so it's not to be used by itself, it's to be used as an adjunct to fetal heart rate monitoring. Now, this is an interesting observation to start with. That was in the first observation about ST analysis in the 70s, when the investigators at the time were actually looking at the effect of fetal hypoxia on the fetus, on the brain of the fetus. They were really not looking at the EKG. They had the EKG in order to make sure that they can they can induce, or you know what, I'm going to skip this one and move to the next one. Now, why ST analysis would be useful to monitor fetuses? Well, we know that the myocardium, when the myocardium has enough oxygen delivery to it, it goes through aerobic metabolism. The aerobic metabolism will use glucose and oxygen, and then the output will be carbon dioxide and water. So that's in normal aerobic metabolism. However, when the fetus is hypoxic, the myocardium will still go through a metabolic cycle and produce energy. However, it has to go through an anaerobic metabolic cycle. Now, glucose is used without oxygen. In the absence of oxygen, it has to go through an anaerobic metabolism. It will produce energy. However, this time, instead of carbon dioxide and water, the myocardium will produce lactic acid. The lactic acid then causes release of potassium ions, and the release of potassium ion will elevate the T wave. So the T wave, as we all know, is affected by potassium and potassium concentration. And the ST analysis in the fetus is analogous, is no different than a stress test, treadmill stress test. Patients with angina or patients we would like to screen for coronary artery disease may undergo treadmill testing. where the EKG is continuously monitored while their exercise is increased, and the EKG is specifically monitored for the T wave and the ST segment. So when labor puts the fetus like on a treadmill, the ST or STAN analysis then is used to evaluate the status of the fetus. This is how the device looks. It actually looks a little more modern than current devices, and I have to tell you, in some of the patients that we've used it on so far, patients really like it, nurses like it because it looks more modern than what we have. It's a computer screen as opposed to whatever we see, the digital window that we see in the current machines. The machine, the STAN machine, can do the standard capabilities that we have right now in the equipment that we have now. So it can do external Doppler, it can do scalp electrode measurements, it can do external monitoring of the contractions, and it can also monitor intrauterine pressure. However, in addition to what the current machines do, the STAN machine can also pick up, record the fetal EKG, and analyze the ST segment. In order to do that, you cannot use the regular scalp electrode. You have to use a specific scalp electrode that's gold-plated in order to improve transmission of the signal. The EKG signal is very faint relative to the maternal EKG, so you need a real good pickup of the fetal EKG, and that's why you need a special electrode. So you cannot use the regular electrode with the STAN machine. Now, in a regular electrode, the regular electrode is actually detecting the R wave, because that's the highest peak of the EKG wave. It's detecting the R waves, and it's measuring the distance between the R peaks, so the RR interval, and then it's calculating the fetal heart rate from the RR interval. That's what we currently have, what we currently use with the regular scalp electrode, and that's all. In addition to this, the STAN analysis, the ST analysis, identifies the ST segment and the T wave. So in addition to providing the fetal heart rate of the fetus by calculating the RR interval, the STAN equipment also evaluates the ST segment and the T wave. Now, what it does is, because each fetus may have its own particular ST segment and T wave, depending on the fetal size, depending on the position of the fetus, it has to relate that, it has to standardize that to something that's dependent on the particular fetus. So it standardizes it to the QRS complex. So as you can see, what the machine is doing is comparing the T wave, the height of the T wave here, to the height of the QRS complex. And that's what we call the T-QRS ratio. So what the machine is calculating, is measuring, is the T-QRS ratio. It doesn't give you a T-QRS ratio for every beat. It averages 30 beats and gives you the average T-QRS ratio for these 30 beats. So it's important to note that it's every 30 beats, it's going to give you an average T-QRS ratio. And this is how they would look on the monitor, on the screen. This is not how exactly it will look on the paper that comes out of the monitor. This is how it looks on the screen. We can see here the fetal heart rate. That's the usual fetal heart rate. We can see here the average T-QRS ratio for these 30 beats, and that changes every 30 beats. This is the contraction. If you have an IUPC, it will be in pressure. This is the EKG for that fetus, for that heartbeat. And then this is an event log, where it will log in here all the events that occur during that monitoring. As when you look at the screen, you can see this is the regular fetal heart rate tracing that we normally see. the regular contractions that we normally see, either external or by intrauterine pressure. And then if you look here, you see these x's. These x's are the average TQRS ratio for these 30 beats. Now, the colors here, the white and yellow, are just to improve visualization. It's not because these x's have to be in the white range. This is just to improve visualization. Now, this is a normal tracing. There are no ST events here, and compare that to this tracing where now you have an ST event. So the machine tells you when you have to worry. It tells you when you have to do something because it tells you, it prints out an ST event. You can look at these X's here, and the reason you have an ST event here and here is because you had a rise in the TQRS, but you're not required to look and measure these rises. You can just look if there are any ST events or wait for ST events. These ST events are also logged in the event log here. So it's very easy to use. It's very user friendly. You don't have to do a lot of interpretation. The machine tells you when there is an ST event. Now let's look at a few cases here just to show you how it's used or how beneficial it could be. If you look at this case, this is just a segment of the tracing from this patient. Let's say this patient was 5 centimeters dilated, and this pattern has been ongoing for half an hour. So this is not only now, has been ongoing for half an hour. I'm sure you all agree that this is a category 2 fetal heart rate pattern. It's still a category 2. This is not a category 3. So the question is, what are we going to do? Half an hour of this pattern, the patient is 5 centimeters. What do you want to do? Let's look at another pattern. Again, similar thing. Let's say again 5 centimeters, and she's having these decelerations now. This is still a category 2. So this is what I was saying before, that category 2 is indeterminate, and we need some additional information to decide what to do. Some of us may section both of these patients. Some of us may section one but not the others. But we really don't have a good way to know what to do. So what if I told you now that in the upper panel there were no ST events, while in the lower panel, as you can see, there was ST event? Would that change your management? And that's what we're really talking about, using the ST segment analysis or STAN as an adjunct to cases like this where it's really not clear what to do. Okay, so now maybe you're asking what happened to these patients. Well, because there were no ST events in the top, the patient was allowed to continue through labor and had a normal vaginal delivery with a normal pH and normal outcome, while the one on the bottom had a cesarean section, and the outcome was still good. But the question is really here, had we not done the C-section, or if we didn't know about the ST events and continued the pregnancy, continued the labor, then would we have had this outcome? And the only way to answer this question is through a randomized study where these patients would be randomized to using the ST segment analysis versus not using the ST segment analysis. Okay, so now that I showed you these examples, what is the current status of STAN analysis in clinical practice? Now, the clinical management or the clinical use of STAN depends on an algorithm of management that is based on 3 zones, 3 colored zones of classification for the fetal heart rate pattern. Now, those of you who are going to be involved in the study, in the trial, will have to go through a specific certification and credentialing process, and you will be informed about all of these zones. But briefly, what I want to show is that these 3 zones are very similar to category 1, category 2, and category 3 NICHD and ACOG criteria, except for two areas. Now, obviously, we could have used the category 1, 2, and 3. However, these categories came out after the STAN technology was approved by the FDA, and it was approved by the FDA based on these zones. So we have to use these zones rather than category 1, 2, and 3. And that's in the arm where we use the STAN. So the only two differences between these zones and the categories of fetal heart rate are first one up here, where variable deceleration with a duration less than 60 seconds and a depth less than 60 beats is in the green zone, while in the NICHD ACOG categories, this will be in category 2. However, we all know that these are mild variables. They're variables that are usually not associated with acidosis. So even though they're in category 2 in the NICHD ACOG criteria, they're really a soft category 2, and we may not manage them any different than category 1. So in the STAN criteria, they are in the green zone. The other difference is the one in the red zone, where absent variability regardless of other fetal heart rate patterns is in the red zone. However, if there are no decelerations that, like I showed you before, or no bradycardia, only absent variability with nothing else, this would have been in category 2 according to NICHD and ACOG criteria. However, we all know that absent variability, even without deceleration, is a significant pattern, and therefore in the STAN it's put in the red zone, not in the category 2 or the yellow zone for the STAN analysis. So these are the major two differences between what we're going to use in the STAN versus what is used in NICHD and ACOG criteria. And the reason we need to stay with the zones, with the colored zone in the STAN, is because the management of these patients, the recommendation for management, depends on these zones and depends on whether ST events are present or not. I'm not going to go into too much detail here. Again, you'll go through a whole training before you start using this technology. But briefly, if there are no ST events, then you manage them the same as you would manage category 1, 2, and 3 with the few exceptions. If there are ST events, then you look at the zones where the fetal heart rate is. If it's in the green zone, then ST events don't mean anything and you can continue management. It will only be useful if the ST events are in the yellow zone, and that's why we call it as an adjunct technology. Now note that in the red zone, even without ST events, we still have to intervene, even without ST events, and that would be like a category 3. We have to intervene for these fetal heart rate patterns. Okay, so now that we talked a little bit about the management, about the background, what is the evidence relating to STAN and ST segment analysis? As I said, there are 5 randomized trials currently, but there was a Cochrane review before the 5th trial came out. So the Cochrane review includes 4 of the randomized trials, and most of you probably familiar with the Cochrane review. Basically, this is an international collaboration that looks at evidence for what we do, and they look in the literature, identify the good trials or the good studies, mostly randomized clinical trials, and then they are put together into a summary, into a meta-analysis, and then the recommendations or the findings are provided to everyone. Now in this Cochrane review, they looked, as I said, at the 4 randomized trials that were out by 2007. There is a 5th one, but even if you add that 5th one, the results will not change dramatically. Now this outcome here, this is looking at neonatal encephalopathy, and if you look at the summary at the end, the summary here, that's the last line, would be the summary of these 4 trials, the meta-analysis. you can see there was a reduction in neonatal encephalopathy, and that reduction had a 95% confidence interval that touched 1 but was mostly below 1. That difference was still statistically significant. So there was a significant reduction. There was about 60% reduction in neonatal encephalopathy in the group where ST segment analysis was used as compared to the group where ST segment analysis was not used. There was also a reduction in significant metabolic acidosis that was defined by a cord pH less than 7.05 plus a base deficit more than 12. So this is not just any acidosis, this is significant metabolic acidosis. There was a reduction, however, the reduction was not statistically significant. You can see the 1 is included in the 95% confidence interval. But there was a significant reduction in operative delivery, all operative deliveries, operative vaginal delivery as well as cesarean section. And very dramatically, there was a decrease in fetal blood sampling. Now, what I didn't tell you is all of these trials were done in Europe where fetal blood sampling was used in both arms. So the control arm, even though they didn't have ST analysis, they had regular fetal heart rate monitoring plus scalp sampling when needed. But with the use of ST analysis, there was a decrease in the need for fetal blood sampling. So the providers in the arm where ST analysis was available did not feel like they need to do fetal blood sampling. They could manage these patients without fetal blood sampling. Now, we don't have fetal blood sampling in the United States. So I ask you, whenever in Europe they need to do fetal blood sampling to determine what to do next or how to manage this patient, what do you think we would do in the United States? I would say in the vast majority of these patients, we would do a cesarean section. So to me, this is somewhat of an indication that it could have had even more profound effect on the decrease in cesarean section in places where fetal blood sampling is not available or not used. In addition to the randomized trials and to the Cochrane review, there are multiple, I just list here a few of them, multiple retrospective case control or observational studies, time control studies that show the same thing. Basically, there is a decrease in cord metabolic acidosis, there is a decrease in operative deliveries, there is also an improvement over time that has been reported, that people start to use more and more STAN, ST analysis over time, and become more and more comfortable with ST analysis over time. And it's no different than anything we use. There is a learning curve. For example, you wouldn't take a fresh graduate from medical school or nursing school and just give them fetal heart rate monitor and tell them just manage the patient with fetal heart rate. Most of us, including the nurses, the nursing providers, the midwife providers, will have to go through a training in order to learn how to evaluate the fetal heart rate currently as it is now. So the ST analysis is no different and requires training and time to get used to it. So after I've shown you all this, the rationale and the background and these studies that show a benefit, you're probably asking yourself now, do we need another study? Why not just go and start using it, especially that it is FDA approved? Well, the issue here that we felt and the MFMU network felt still need to be answered and still requires another study is that there are differences in our practice patterns as well as our patient population between the US and where these studies were performed, mostly in Europe. For example, we have different approaches to operative vaginal deliveries. Some places in Europe, they do more operative deliveries. Some places do less. We don't do fetal blood sampling, and obviously most of these studies included fetal blood sampling. And also, almost all of these studies, or most of these studies, I shouldn't say almost all, most of these studies in the arm where STAN was not used, in the monitoring, fetal heart rate monitoring arm, they used intermittent monitoring rather than continuous monitoring like we do here. So there are certain differences, and some of these differences may make STAN look better in the US. Some of these differences may make it look worse. And therefore, we, as well as the MFMU, feel that we still need a randomized trial that's done in the US. Now, just to show you one study that already published from the US, this is not a randomized trial. This is a prospective trial where patients were put on the STAN, and US physicians were managed these patients. And the whole purpose of this study was to see if the US physicians can agree with the experts, mostly experts from Europe, could agree with these experts. And this was a required study by the FDA before they approved the technology. But you can, or there are certain things that should be brought up in this study. First of all, there was good agreement, even better agreement between the US physicians and the STAN expert, better agreement than the inter and intra-observer variabilities that we know of with regular fetal heart rate monitoring. But more importantly is this graph here. This, in the x-axis, these are the cord artery pHs, and the y-axis is the number of cases with at each of these cord artery pHs. So in the gray columns, these are the total number of cases that had that particular cord artery pH. In the dark columns, these are the number of cases for each pH that was felt to have non-reassuring fetal heart rate pattern. So you can see there was quite a significant number of cases at each of these pHs with non-reassuring fetal heart rate pattern. And all of these, most all of these, were in the normal range of cord gases. Now, if you look at the triangles, these are the proportion of cases that had STAN guideline indications for intervention. So that's based on the STAN evaluation. These were felt to need some more intervention or some more observation. And then you can clearly see that with these normal pHs, there were fewer babies detected by STAN than there were babies detected by regular fetal heart rate tracing as needing some intervention or some observation or some indications. Now again, this is not a randomized study, and it's not possible to use this to determine whether it will be beneficial or not, but it gives us some indication that at least in the normal range pHs, the STAN guidelines will tell us will have less false positive than the regular fetal heart rate monitoring. So based on what I told you and based on the information that we have, the NICHD MFMU network decided to perform a randomized trial to look at the benefit or the value of STAN as an adjunct to fetal heart rate monitoring. So that was basically the basis for the design of the trial, and I want to stress again, this is as an adjunct to electronic fetal heart rate monitoring. Now the proposal is we're going to enroll 11,000 women, so that's quite a large study. It's actually much larger, also almost twice as large as any study done so far. So that is really once and for all study to answer that question. The patients, these 11,000 patients, will be randomized to regular fetal heart rate monitoring plus STAN versus regular fetal heart rate monitoring and masked STAN. So in the masked STAN, you will use the same equipment, but you will not see the ST analysis result. You will not see the number, the TQRS number. You will not see the X's on the bottom. They will be monitored they will be in the machine. They will be stored in the machine for later analysis, but you will not see them, while in the other arm you'll be able to see them. So this is the ideal way to determine whether STAN added to fetal heart rate monitoring is going to improve outcome. And we specifically chose a primary outcome that is significant and a neonatal adverse outcome. We did not want to choose a cesarean section as an outcome, but on the other hand, using this outcome resulted in a much larger sample size. That's why we have 11,000 patients to include. We also have secondary outcome, mainly for safety, cesarean section, maternal outcome. There are specific eligibilities, and the research nurses at your institution will go over these and make sure that the patient is eligible. There are also exclusions that we need to be aware of. Now, 3 key issues that we really need your help with and assistance. First, as you may have noticed before, metabolic acidosis is one of the key outcomes, primary outcomes. Therefore, we need cord gases. We cannot determine metabolic acidosis unless we have the cord gases. So we need cord gases on every case. Now, we understand some cases you may not be able to get cord gases, but these should be the minority. Otherwise, we cannot assign the primary outcome. So we need your assistance and cooperation in order to get the cord gases, and it has to be an arterial cord gases. We need both arterial and venous, but obviously the arterial is the most important one. The venous is mainly to tell us we don't have 2 venous samples. We also, another key issue that's clear from all the trials is that there should be continued education of the providers. We need to have providers who understand the technology, who understand how it can be used, and understand the management. Therefore, we're going to have a run-in period. So at your site, there will be a period of time where we're just going to use the technology without randomization in order to train people and get people familiar with the use of the STAN management. Now, let me say a few words at the end here, because anticipate that some of you may be thinking that this is similar to the FOX trial. Most of you were in a prior study called the FOX study, which was about the pulse oximetry trial. And you may remember that trial, and you may think, oh, this is another trial like the pulse oximetry trial. So I wanted to dispel this notion or this feeling and tell you why this is not the FOX trial. Well, first, there have been more prior research on the STAN than there was on the pulse oximetry before the FOX trial started. There was basically one US randomized trial with pulse oximetry before the FOX trial started. As I showed you, there are 5 randomized trials with the STAN. All prior randomized trials show benefit, while the randomized trial with the pulse oximetry before the FOX trial did not show a benefit. In this trial, we include nulliparous and multiparous patients, while in the prior trial, in the FOX trial, only nulliparous women were included. The primary outcome in the STAN trial is neonatal, not cesarean section like in the FOX trial. And the pulse oximetry had a lot of in situations where the signal was lost and needed adjustment, while in this one the signal loss is really much less likely. And finally, the pulse oximetry trial or the FOX trial did not include any training or algorithm for management, while this one will have a specific training and algorithm for the management of these patients. This is from the Neoventa website, the company that makes the STAN, and it's a message from the heart. But I also want to thank you for taking the time to stay with me until the end, and also again thank you in advance for enrolling your patients or helping with this trial. If you have any questions, please ask your MFMU coordinator or your research nurses, or you can even contact me. They have my contact information, and I'll be happy to answer any questions or take any of your comments. Thank you again.